Hi everyone. Today I want to share with you interesting clinical case where I treated deep caries lesion with a pulp explosion. With a good planning, we managed to keep the tooth vital. I will guide you through all the flow step by step. So let's take a look. Here is an X-ray of this case. As you can see, a deep caries on the upper second premolar. As always, I use Tuco art to communicate with my patient that clearly shows the diagnosis. In this case, caries and outlining the proceed treatment associated risk and alternative options. It makes the decision-making process transparent and helps patient feel informed and confident. Okay, so straight to our case. Here you can see I start prep by using round burr and how enamel cracks because of the caries underneath it. I'm using my round burr to prep the enamel and the wall of the tooth. I see some food stuck in there. Believe it was patient breakfast. I will then remove it and continue with the round burr apically, and then remove some infected dentin and enamel. Some undercuts here you can see, but then I switch to cylindric burr, diamond burr, to reduce the enamel, to prep the tooth, to reduce the undercuts in the enamel, and prepare the tooth for the matrix system. You can see how soft dentin was in this case. Then I switch to carbide burr and use it on the dentin, on dentin enamel junction. We then isolate with a rubber dam. We continue with a carbide burr on dentin. After shaping the cavity, I applied caries detector to confirm that we have cleaned all the infected dentin. The goal for that moment was to avoid the pulp exposure. True, we were very close to the pulp on the X-ray. As we know, X-rays don't always reflect the actual condition 100%. There was a poor contact between the fifth and the sixth tooth, making hygiene more difficult, so we agreed with the patient to first restore the tooth number 5, observe the outcome, and then, if needed, rebuild the contact on the tooth number 6. We checked the vitality of the tooth before prep and discussed all possible complications with the patient and wrote it down in the Trico app. I proceed very slowly, walking along the periphery on dentin enamel junction, lowering my RPMs in intermittently turning off water spray. We're still walking carefully near the enamel dentin junction, making sure all infectant is removed. Eventually, we got pulp exposed, but it's fine, it was controlled. I noticed some bleeding. You can see it in a moment here. Yeah, so you can see it here. Um, we see some bleeding from the pulp chamber, and that's fine. We're prepared for this. I did the area with a cotton pallet soaked in sodium hypochlorite to disinfect and control bleeding. I just moved my microscope up, and then we, with a patient and with the assistant, waited for several minutes. And after a few minutes, the bleeding stops completely. You can see it here. I then dry the area with a sterile cotton pallet and applied bioceramic material with a sterile instrument here. That was total quill putty in this case. I adapted gently to surface. Looking at the footage now, I realized I would probably reduce the coverage area slightly next time. I'm using my micro brush to remove all the excess of this bioceramic, and then over the bioceramic, I place self-etch and self-adhesive flowable composite. It was Vertis Flow, ensuring it fully covers the bioceramic all the way. Again, next time I would use a smaller MTA spot to limit the transition zone. We proceed by placing the metric system as normal, etching, rising, applying bonding. The contact wasn't perfect, but the patient and I had already agreed that we would like to reduce the contact on the tooth number 6 lately. And as of today, the patient hasn't come back for that. She is happy with the result. For the layering, I'm using my favorite composite for now, Asteria. and you can see I'm bonding the tooth now, light curing it, and using flowable highly filled composite to fill the undercuts and cover the dentin from the IDS, light curing it, and then rebuilding the wall of the tooth with the packable composite Asteria, using some Allen instruments, micro brush to adapt the composite to surface to enamel, making contact on the between the teeth and shaping the anatomy of proximal wall with this instrument. Um, For the internal volume of this tooth for rebuild the dentin, I used again flowable composite, highly packed one. Light cure it, remove the matrix, and then proceed with layer of composite with Asteria using brush and some LM instrument. And in this case, here you can see endophiles to perform better to make the better anatomy of the tooth using some small portions of composite, adapting it again, and light curing it. We polished, removing the oxygen inhibited layer with airflow. Then I use some discs to polish the wall and using Enhance and Arkansas burr to refine the enamel composite transition. Final shine is done with Opti1 step and God polisher. I also used finishing strips to polish the proximal surface. The recall for this case is 1.5 years for now, and the tooth remains vital. So we can confidently consider it as a successful case. As always, we remind patient that if any pain arise, any symptoms, so if tooth no longer responds to vitality test, we need to perform with endodontic treatment. If you have any question about this case, feel free to drop below in the comment section. And if you are looking for a better way to communicate with your patients, to explain treatment plans, again, more patient acceptance, definitely check out the Trico app. It makes it easier to show the diagnosis, treatment option, risks, and alternatives, all in way patient can actually understand it. Links are down below. And don't forget to subscribe. I will show you more clinical cases like this, real cases, to help you level up your skills and to improve your practice and make it even stronger. Goodbye.